process of centering our x-ray machine to see the L5S1 disc. Now our patient has severe scoliosis, and that's not something we're fixing today. But we need to try to get into that L5S1 and the L45 disc so I could try to repair them. I think it's not horrible, but we could do better. So try to line the end plate of 5 up. Now our patient has pain in the back and it's radiating into the left side. He's also got problems with his veins. We talked about that ahead of time. I'm not fixing his veins. He needs probably a laser surgery on the veins to help him with that. I think we're going to have to do some of this rotational stuff. Try a little of that. See what we can do. Yeah. Now try some more WAG. Let's get the table up a little bit, please. About an inch. Table up an inch. Yeah, we're not doing anything yet, so he should be fine. Table up an inch, please. I need the table up an inch. Oh, yeah. That's quite all right. I need you to get that 5-1 centered in the middle of the screen. That's too far off, and you're getting too much light. That's good. Again, he was breathing at that moment. All right, so Jordan, we need to get that 5-1 looking better. So I'd say it needs some serious WAG, one way or the other. All right, so the first thing we got to do is, the hardest part sometimes is getting the spine lined up with the fluoro so I can navigate down with the tip of the needle to where I need to go. And Jordan's having a heck of a time trying to get this thing lined up because our patient has severe scoliosis. Now, there's not much we can do about it except try to work around it. All right, lay still. If you get up, you're making it even harder, and it's hard enough as it is. All right, now your WAG is not bad, Jordan. The WAG is not bad. I think the rotational thing. Just lay still, don't move. Other way. I think. That's better. Let's drop the table ½ inch, please. Drop it. There's no doubt. Drop it. That's good. Let's see. This is going to be one of my most challenging ones I've ever done. Let's drop it just another ½ inch. That's pretty good. All right, don't move, okay? Just try to lay still. I'm going to go a little lower. Yep. You're doing great. Just lay still, okay? So we're numbing the skin up. And I stopped with the needle because the reality is that he seems to be bleeding a little more than I'm happy with. He's not on anti-inflammatories, right? No. All right. Just lay still. Sean? So this is going to be a real challenge to get to where we need to go. Just lay still. He's moving around, and that's not helping. Are you uncomfortable? Sean? Huh? What's hurting you? What? What's hurting you, AP? Yeah, you just need to lay still. There's no way we can do this without putting a probe. So that's going to be there. Just lay still and everything will be fine. Are you on any blood thinners? He's on the aspirin, right? But he stopped it. Okay, that looks good. Back to a lateral. So if I can get into 5-1, it's honestly nothing short of a miracle. because of how much, you can see the scoliosis at the top of the x-ray, how twisted his spine is. We're not going to fix the scoliosis. It's not why we're here. Go ahead and put it back to where you were. What are you doing? You're hitting something? Not sure. We shouldn't be hitting his arm. Lay still. It's okay. But you got to go under the drape to check. Why wouldn't you just... Yeah, come on over and go under the drape and look. Lift it up. What are you hitting? Can you see? Just feel with your hands. I'm sorry? Let your nose is running like a spigot? Does that typically happen? You have sinus problems? Got it. All right. Jordan, what do we got here, buddy? His arms are in surrender. Yeah. Let me know when you're ready. Jordan. Sure. You're way too far south. Okay. You're doing great. Let's get in there. Let me know when you're ready. Why is the table so high? You need to raise the floor up. Maybe that's where you're hitting. All right, let's take a shot. All right, that's pretty good. Are you okay, sir? Can you hear me? Yep. All right. Shot. Honestly don't know how I did that. They say it's better to be lucky than good, and I am very lucky. All right, are you okay? AP, I don't know how I got in there. Honestly, that's like hitting a horsefly on the side of a barn from 2,000 yards with a tennis ball. I mean, that's incredible. I got lucky, so I'm very happy. I'll take it. You got lucky. We got into your 5-1. I mean, most surgeons that, there are very few endoscopic surgeons, but they don't do 5-1 transforaminal. And we got in. We finessed it in, as my son would say. Are you okay? All right, just lay still. Huh? Your whole spine is twisted and degenerated, and it's just giving me a fit, but we're going to get there. We got half of it done, all right? Everything's going better than I expected. I'm just surprised that it's going as well as it is. God is smiling on you and me both. You understand what I'm saying? Huh? God is smiling on you and me both. I'm lucky. I'm very lucky here. All right, let's get the next one. I need to line up. I mean, it's not terrible, 4-5, but there's something, for some reason, I can't see it. There, that's better. That is rotated. Yowza. So you can see the L4 pedicles, you see the L5 pedicles, and you can see there's a massive facet at 4-5, full of arthritis. And I got to get around it. Shot? And again, I'd be very thankful if I get a little bit lucky. Lay still. Where does that hurt you? Where does that hurt you? No, 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 no. You say my back. You say my leg. Your back. Your back, sir? That's referred pain. Shot. We're awfully close. AP. We're right in the foramen, low, where we want to be, just above the pedicles of 5. And now we're just at the back of the disc, I believe. What's your hand? So we've already had like probably 8 drops of blood, which is still nothing. All right, lateral, it's good. And that's because he takes, I think he took an anti-inflammatory. Not today, but in the recent past. You really want to give anti-inflammatories about a week to 10 days to wear out. But, you know, I think it's acceptable risk to do it with a few days off. Are you comfortable, sir? Shut. Sir, are you comfortable?
Yes.
Has he had anything sedation-wise, huh?
Yeah, he's had 2 reverse ed.
Just now or when?
Then we got some of it at the beginning, and I just gave him a little more fentanyl.
I'm just wondering how painful this is for him. All right, I apologize. We're almost done. Sean? So I'm right there. I think we need to slip up a little bit. Slip the needle upwards. You okay? Are you okay?
Yes.
Yeah, don't pick your head up. You can talk to me, but don't try to get off, move around, okay? All right. All right. Well, the good news is we're pretty darn close on your second disc. Give me an AP. I'd like to get it in a little bit more than it is. But we're awfully close. Yeah, I knew it. It was just rubbing on the top, the superior end plate of 5. If I could just get it to... Oh, there it is. There it is. Where do you feel that, Sean? Yeah. You're doing great, sir. You're doing great. All right. Now, you have back pain every day, right? You have back pain every day? You want to get rid of that back pain? Of course you do. That's why you're here, right? We're going to be able to get rid of it soon. But I need to test something real quick. Is that your typical pain? Is that where you get back pain? How bad is that on a scale of 1 to 10? What's the worst it got? 8? Did it get to a 10? No? So it got up to an 8. That's okay. It's okay. An 8. I just need to know the number that it got up to. It's an 8. And that was L5S1. 8 out of 10. Is that where you typically get pain in your back?
Yeah, when I have that pain,
Yeah.
goes down my legs, and it's like really like...
Jeez. How bad did that get on a scale of 1 to 10?
I'd say about 8, 7,
So 2 8s. 8 at 4, 5, and 5, 1. All right, here you go. All righty. I like to start with 5, 1. I guess we're ready to go to sleep. We're going to try? I don't know if we should try. Probably not the right one. We've been lucky. I don't want to push my luck. It is not the right one to try without propofol. No. You do whatever is safe for the patient, and I'll deal with the rest. As long as he isn't coming off the table, we're fine. All right. So we did a discogram on both discs, and basically what we found, look at all the scar tissue in the back of that disc. What we found is that this patient does have back pain coming from these two discs that we're operating on today. The back pain is 8 out of 10 when we tested it, and that's not as important as the fact that it is his typical back pain that he always gets. So, shot, that's it right there. All right, we got the guide wire in. We've already made our incision. This is not a percutaneous surgery. A lot of people think this is percutaneous. It's not. What percutaneous is, it means it's done with a needle. So, I'll show you what I'm talking about. Can you see here? Just lay still, you're doing good. Give me some num-num. You're doing fine, that's just the fascia. Can this go in? Huh? Does this, I don't think this needle will fit in here. Will it, Louise? Oh, it does. I'll be damned. All right. There we go. Don't let it come up. Shot. That's it there? Good. All right. So, you ready? Just don't move, okay? You're doing great. Yeah. All right. All right, just take it easy. Let me have some more numbing. Just keep it on the. You're okay. That's just me going down to the spine. So for those of you watching wondering, well, why aren't you putting the patient to sleep? We are. But we don't want to put them too deep. Why? All right, I'm just giving you more numbing medicine, that's all. You're doing fine. Just lay still. Lay still. Let me know when I can proceed. You're doing great. Just lay still. Everything's fine. I know it's a little uncomfortable. Shot. Are you pulsing? All right, let me know when I can bring this and get it down into the disc. Okay, lay still. All right. So for those of you wondering, well, why are you not just putting them deeper asleep? Well, the patient doesn't have a secure airway. What that means is, let me know when I can proceed, okay, Dr. Freed? Dr. Freed? Dr. Freed, I'm just going to wait until you get them a little bit sleepier. So these surgeries, I need my patients talking to me for the first part of the surgery. You're doing good. And for a patient to talk, they can't have a tube down their throat, otherwise they can't talk. So they have to be awake. There's no other way. And what I do is once I get the discogram done, I actually will let the patient go to sleep. So this patient is going to be titrated with propofol till he's, a little more asleep, maybe some other concoction the anesthesiologist wants to use. But the key is we don't want this patient to stop breathing. You're doing good. Just hang in there. You don't want him to stop breathing and obstruct his airway, because then he won't breathe and it becomes a risk of a life or death situation. So there's a really delicate balance between being too much awake or too much asleep. And you want to get it right, perfect for every patient. And every patient's different. Some patients require more medicine to make them sleepy. Other patients require less. So the anesthesiologist has to what's called titrate, which means give us slightly more every few minutes. Check the patient, check their level of awareness, check their level of pain, check their level of breathing, their vitals. It's called titration. All right, that's better, I think. Let's go. Now I got to get down into the spine before he wakes up. Otherwise, it'll be uncomfortable. You ready, sir? Just wait or go. So, Shot. This dilator is actually following the guide wire. Okay? Just, you're doing great. Everything's okay. Lay still. Just lay still. You're doing fine. Shot. Yep. There she blows. All right. Let's take this out. Take it. Now, I'm not in enough, so now I am. But you see that? It was really good because he got better pain control, and then the patient relaxed his muscles because he wasn't in pain, and I was able to get into the disc nicely. So it's really a coordinated effort, Shot, between the anesthesiologist and the surgeon to time it and have it done, Shot, just right. And that's what we aim for. Lay still. You're doing good. That's it, right there. You're done. We're done. You're doing good. All right. How is he? Is it okay? Is he in a happy place yet? We may need the vice grip on this one. Yeah, I would have it ready just in case. Shot. Egads. Shoo-wee. Look at that. I never squeezed so hard. Lay still. You're doing all right. Lay still. Oh yeah, I forgot to mention. A lot of patients stop following commands and they become very difficult to control when they get sedated. We don't like it. Shot. All right. Making a little progress. Is he okay? I don't mind squirrely. Huh? Shot. All right, get the floor out. Oh. Got it. Let's go.
Don't move, my friend.
Lay still, you're fine. Understood. Yeah. Yes. Well, do your best to keep them as comfortable as we safely can. All right, let's get this going. I need irrigation. I need the scope. Pull the fluoro back a little bit, please. I don't know why you have it so close. Let's go, Jordan. Come on, move it back. That's good. All right. We are inside the 5-1 disc. There it is. There's the disc herniation. I shoved it back into the disc. So just keep them as comfortable as you can. Lay still. And again, it's unfortunate, but in some patients it is a race of time. Get it done quick before they come right off the table. So all these drugs we give patients that create this analgesia, amnesia, basically anesthesia, all of them are psychoactive. They all inhibit or disinhibit, I mean, certain parts of the brain. And some of those areas cause excitation of the motor areas. The patient starts moving around more. You're doing great. Lay still. Lay still. So, lay still. You're doing good. My pedal, where is it? Good job on the laser, having it ready to go. So I use a combination of laser and pituitary rongeurs. Really, the vast majority of the work is done by the laser. The pituitaries just grab out pieces of disc herniation that I free up. Lay still. The reason we broadcast these surgeries so people can watch and learn. Don't think for one moment we broadcast these surgeries because they're sexy. But you get to see what happens in the operating room, you know? And sometimes it isn't pretty, but that's okay. That's all part of it, you know? We want a reality experience so people can see it. All right, for those of you watching, you're welcome to ask some questions, okay? If you want to know something. Again, we're in the L5S1 disc. Lay still. Now, these kind of surgeries only work when people are cooperating. And right now, he's on the border of not being very cooperative. We don't get too many like this. Most people are very cooperative. They get comfortable. They go to sleep. So, what is that medication? The dissociative anesthesia medicine. I forgot. Ketamine. You like that stuff at all?
Yeah, I had some thought I was going to give to him, but I didn't.
I would. I mean, whatever you want to do, it's your choice. But he is with the.
No, I was thinking about giving.
Oh, he will get worse. In that case, don't. But you can see. Lay still. Well, it's going good. And I'm working quickly. So we can be done quickly. Gosh, what's amazing to me is this guy's spine is so degenerated, and yet look at this disc. Still here. Soft disc. You'd think it'd be long gone based on the appearance of the spine. That this soft disc material will be dried up and wouldn't even be here. It's like finding an oasis in the middle of a desert. You don't lay still. Sorry, folks. I know it seems bad to you all, but to us, we're used to having to yell at our patients sometimes. We're not really yelling at him. He's just half asleep, half awake. And imagine somebody sleepwalking in your house, right? You don't want them sleepwalking on the street. So you got to guide them. Sometimes you got to yell at them and say, hey, get off the street. You're sleepwalking. Lay still. You're fine. Yeah. I'm almost done here, Doc. How is he? Besides uncooperative. Otherwise okay? Breathing good? Ventilating, oxygenating. Huh? Son of a bitch. Yeah. We're in the most painful part of his disc right now. I'm on the outer half of the annulus, so we're right where the herniation's been. I'm doing an annular debridement. It's going well, but this is unfortunately the painful area, which we need to get to eventually, right? So here it is. Seems to be doing better right now. All right, just cleaning up this tear. I think he's going to be real happy when he's all healed up. Wipe. You wipe the tip, right?
Oh,
I don't know that you got the tip. All right. Looks good. Thank you, Luis. So, today's Thursday. Now, for those of you who watched the surgery before this, we did a posterior cervical decompression infusion, multi-level C3 to C7 decompressive laminectomy with foraminotomies, standby laser, grabber, and then I did an instrumented fusion from C3 to T2 with C3, C4, C5, C6, C7, T1 and T2, screws and rods. Lay still. Don't move. You're moving too much. This is all the herniation that's pushing on the nerve. I shoved it back into the disc space, and now I'm removing it. Wonderful stuff. Anyway, the last case we did lateral mass, screws, at C3, 4, 5, 6, 7. And I did pedicle screws at T1 and T2 on both sides. And she's just about ready to go home. Lay down. Why am I getting irrigation all the fuck over me? You're supposed to have this wrapped. Why is it not wrapped, Luis? My shoe is soaking wet. I know it's a... Yes, you have a question there, Sean.
We do. One of our viewers from YouTube is wondering what is the worst thing that could happen if the patient does not listen and moves around too much?
Oh, good question. So one of the viewers says, Dr. Duke, we see you're struggling to keep that patient laying still. What's the worst thing that can happen? The worst thing I think that can happen is they could fall off this table onto the floor. That would not be good. We're not going to let that happen. They are strapped on. We strap our patients down, but when they move so much, I mean, those straps will just come right off. So I think the worst thing that would happen is the patient would fall on the floor. It's not that I'm going to do nerve damage, because you can see the endoscope actually moves because it's anchored in the spine. It moves with the patient. So it doesn't, I'm not worried about damaging something down here. I'm worried about the patient falling on the floor. That would be the most damaging thing that could happen. So as long as our patient doesn't fall on the floor, he may not like us too much when he wakes up, if he can remember everything. But that's not so bad. This is a lot worse than I thought. Yeah, I've had patients move before, and honestly, I'll take a moving patient any day over a patient who stops breathing. So stopping breathing is not something anybody in here wants. So we'd rather have the patient a little light, being a little bit awake and a little uncooperative any day over stop breathing. All right, we're pretty much done here. Just got to get the tiniest bit left of this disc. This is where the nerve was getting pinched, right in this area. Just want to finish this up. Little fat in the frame in there. And you see, I put the grabber in there several times, and you could see that the grabber is not very effective. It's not effective at all. And the grabber is literally the best tool non-laser spine surgeons have. Of course, there's a drill. I could get a drill in here and start drilling, but that's a bit dangerous. But it works. Doesn't work as good as a laser. 30 seconds. just want to get this area right here. Oh yeah, and this is the part he's not liking. What is it?
No, explain somewhere. Review her. How to deal with them.
I always talk about the disc being the source of back and neck pain. It's actually the back of the disc on the sides, right where we are. That seems to be the area that's the most painful for people. All right. Let me get the grabber. Let's see what I can grab, and then we're done. So we've opened the foramen. We've done a transforaminal discectomy here. What you're seeing that's left there are the end plates, a little bit of epidural fat, and I can't really get anything else out. Try one more time with the laser and we're done. How's he doing? You doing a jaw thrust? Oh, good. Yeah, he's not happy about it. People who say the disc doesn't hurt, well, come do what the anesthesiologist is doing right now, because he can feel it. As soon as the laser comes on, he feels it. You can tell, right? Can't you? Soon, huh? All right, well, I'm just about done. So, they're all coming out. You've got some allergies, huh? All right. I'm happy with that. The nerve root's going to be up there. That's just fat. Lay down. You're doing fine. Don't move. Oh, I love it. This is all posterior annulus inflamed. The disc herniation is now gone. I'm going to show you guys the nerve root, all right? It's at the top of the foramen right up here. It's pretty cool. Take that. You guys ready? It's going to be right up here. Ah, it's in too much fat. But, oh well. Sorry, I thought I could show it to you, but there's too much fat around it. All right, well, it's right up there. We're done. Lay still. Sucking all the juice out. My God. Is there no suction on this thing or what? Why is it so hard to suck this tube? There we go. All right, done. Scope off. Is he okay? Little white magic. Let's move this. Lay still. You're doing good. All right. So we've done the L5S1 level. We're going to do the L45 next as long as it's safe to proceed. If our anesthesiologist says no, we don't. We're good? All right, bring the fluoro in quickly. Huh? All right. But he's safe, in your opinion? Let's go. All right.
If it's too wet, we can put towels.
Let me know when you're ready. Wow, you're up in the thoracic spine there. All right, let's get a picture. Okay, not bad. Just leave it there. All right. So, let's take the needle out. Shot. That looks good. Guide wires all the way to the front of the disc. Don't want to go any further than that. And we'll bring our dilator in. I just need to know when I can safely advance the dilator. Shot. You just let me know, okay? Doc. And if we have to stop, we can stop. Lay still. Shot. Lay still. He's just coughing. Yeah, he's just coughing, right? Yeah. Let me know when I can move forward. Hold this here. So, this is honestly one of the tougher cases, not because it took me a longer time to get in. Shot. I actually got in pretty quick. I'm pretty happy about that, but the reason it's so tough is this patient has a lot of, I guess, sinus disease, and it's affecting his he's getting a lot of drainage, basically. You want me to wait? Lay still. Huh? Shot. Shot. All right, let's pull this back. Shot. All right, so just another minute. We'll be in. Shot. There's kind of a double shadow there. Take. We're in. But the fluoro is really off. Like off position. I think we're good there. Can you try to improve that a little bit, Jordan? Why am I not going in here? We need a new tube. This thing's not going in.
I need new.
Just get me a new tube.
Can I have more? Back there.
We need a new tube.
Yeah.
She know where it is?
Back there. Yeah. So in the cabinet, so you see where it says like wire? Right there.
Oh. That's fine. No, I'm just applying pressure for the blood. There's really nothing really coming out, but. All right, so basically this is the L4-5 at this moment. I have a dilator in the disc space. The patient is breathing. He just kind of heaves and hoes a bit, but he's not in pain. He's comfortable. And I need a tube. Because the disc we just did may have compressed the tube a little bit, because these are not, they're stainless steel. Actually, I got it. So it was tiny bit narrowed, but I was able to work it on. I think we're fine. We'll see. It's good that we have that available if we need it. All right, is that my picture? Yes, sir. All right.
Thank you.
Any way you can improve the view a little? Yeah, it's going to be that. Shot. It's really hard to tell. Do you remember where we had it set last time? Keep going. Yeah, I think we still need to go in further. Shot. Let's get the dilator out. Shot. Make sure we're in. It looks good. Take. All right. You hear that sucking noise? Fluoro out. That is something called vacuum space phenomena. Degenerated discs that are severely degenerated, they actually have a vacuum. Kind of like the old light bulbs. My God, old light bulbs. Think about that. These young kids are never going to know the old light bulbs that are vacuum sealed. And you used to break the little contacts at the bottom, and then you hear a sucking noise. We did that as kids. When you grow up without without a lot of money, old light bulbs become your toys. I need something here, Luis.
Lights off, please.
Come on. I really need a little bit more play. Uh-huh. Just don't pull anything contaminated on. All right, here we go. So, what's going on here? Why am I not getting better illumination? That's inside the disc right there. All right, there is our problem area right there. Let me have a laser. That, that is an inflammatory mass if I've ever seen one. Huh? That's where a lot of the pain is coming from. Wow. Just like that, gone. How's our irrigation? Good? All right, thanks. See the end plate there? This is the annular tear. We're debriding it. The annulus is white. The tear is always going to be like a white. There, you see it? Those torn fibers? Got to clean them up, otherwise it won't heal. And again, this is that problem area. Those are quite literally ingrowth of new blood vessels and nerves. I need literally 2 minutes, doctor, and we'll be done. Yeah, I know, he's good, and I appreciate that. But unless this thing just is really stubborn, which it could be. All right. This is the inflammatory mass that's been causing his pain. It's normally not this prominent. In other words, in a lot of patients, it's not so obvious. It's more subtle. I don't know why. Just everybody's a little bit different, you know? You never know what to expect when you get in here. That's calcified herniation. Sean, any questions from our audience?
None so far.
We're going to be done in about 3 minutes, folks. So, laser, if you have a question, this is the time to ask it. I'll be finished up here in just about 3 minutes. And then I'll take questions in the conference room if you want to type them up. But we're at the back of the disc right now. And this is just the corner of the back of the disc. And you can see all the pinkness. That's all inflammation. This is where his pain's coming from. And it's due to the annular tear that's inflamed. And again, that's my discovery at Duke Spine, Dr. Duke Majan. I discovered this, and basically by removing this little nidus of inflammation, we're able to cure back pain when it comes from a herniated disc. Now, obviously, back pain from a fracture won't get better with this surgery, but back pain from a herniated disc will. And a lot of people have pain from more than one disc. So the key is to make the right diagnosis. Is it the L4-5 disc? Is it the L4-5 and L5-S1 disc? Which discs are causing the pain? You have to figure that out before you go to surgery. There's no way to figure it out in surgery. I mean, the discogram can help you, certainly, but 99% of our patients, we know before we even come to the operating room what discs are causing that pain. So we know exactly what needs to be done in surgery. Okay? So your doctor should be able to figure that out. That's fat right there. The best pain doctors in the world can figure it out. You're not going to get it done everywhere, but if you want to come to Duke Spine, we'll be happy to take care of you. All right, that's L4-5. And I think we're pretty much done. That was easy. Huh? Easy for me, but not the anesthesiologist. He, huh? Oh. No, I mean, you did a great job, but you had this is a difficult patient from an airway standpoint and from from a anesthetic standpoint. Oh yeah. He's got a lot of a lot. The good news is with a great anesthesiologist you can minimize many of the problems that would normally be insurmountable in anesthesia. People don't realize how hard good anesthesia really is to do, but it is hard. They take it for granted. All right, we're done. We're going to close this thing up. You got this, Luis? You got this, Luis. Oh, let's show our audience what we got here. All right, folks, take a look. We're going to go see our posterior cervical fusion in a minute, but this is his back. Can you see, Sean?
Yes, we can.
All right, you ready? I'm going to move it. We did both disc surgeries. He has horrible scoliosis, and most surgeons would be doing a major back surgery with screws and rods, and patient might make it, they might not. It's done at the hospital. They might get COVID. They might not. They might get another infection. They might not. The point is here, in 15 years of doing these surgeries, we've had 0 complications. Go ahead. 0. And that's over 1,200 procedures. This is the safest spine surgery in the world for back pain and neck pain. And we've doing thoracic as well. I'll be in the conference room in a minute. I'll call our EBL 10 mil. Thank you. Go ahead and type up your questions. And I'll answer them for you, folks. Again, Duke laser disc repair, endoscopic spine surgery, only done here at Duke Spine Institute. Literally 20 years ahead of the rest of the world spine surgeons in spine surgery. Maybe 20, 30 years from now, they'll be doing this kind of stuff once they figure out how to do it.
All right, everyone, we're in with the post-op Q&A now. We have Dr. Duke at the table with us, ready to answer your questions. We have a couple questions that came in from YouTube, the first of which comes from a viewer who asks, Dr. Duke, how can you do laser surgery on someone with scoliosis? Doesn't the deformity cause more problems in the future if it's not fixed with fusion?
Hello, YouTube questioner. How are you? Great question. So the question was, Dr. Duke, you got a patient with deformity, which we all know what that means now. We've been talking about it for a while. Spinal deformities are typically characterized by changes in alignment of the spine that occur in one of three planes. Okay, so slippage of bones, one on the other. Forward is called anterolisthesis, backward retrolisthesis, sideways lateral listhesis. Listhesis means to slip. When the curves of the spine in what's called the sagittal plane, so if you look at the side of a person from sideways, and you're looking at the three different regions of the spine, cervical, thoracic, lumbar, nobody really pays attention to sacrum, but that is the fourth part. So if you look at the side of a person, the curves that you see at the side view are your sagittal curves. And so when you have the curve change and go from curved backwards to curved forward, it's called kyphosis. On the other hand, if you go from curved forward, like in the thoracic spine, to curved backward, it's called lordosis. That never really happens. Kyphosis is really the problem, not lordosis. And when your lordotic regions, cervical and lumbar, which are very mobile and susceptible to injury and deformity, when they start shifting their curve from lordotic to kyphotic, or straight even, patients get horrible pain and problems like that. The last shift occurs in the coronal plane. So if you're looking at the patient from the front to the back, any kind of malalignment of the spine off to the side there usually occurs with rotation. Now, I'm not talking about traumatic deformity like a fracture dislocation of the spine. We're not talking about those. Those are not common. And they obviously are associated with high impact, high trauma, high energy injuries like falls and motor vehicle accidents. So I'm talking about basically what are called degenerative deformities, which occur in spines as people get older and the effects of gravity occur. They are primarily what are called glacial instability, which means the spine shifts, bones and vertebrae shift position slowly over time by very, very small amounts every day, not, a lot, not a rapid sudden change. So the scoliosis this patient we just did has, it's a glacial instability. It's a slow rotational change, usually due to abnormal problems with the disc or the facet joints. So if there's a disc injury or facet joint injury, those are what keep the spine aligned properly. Once you injure a disc or facet, then the spine can subside, which means kind of settle from gravity, and it can twist as it's subsiding or as it's settling. And that twisting is called scoliosis or degenerative scoliosis in the case of degenerative scoliosis. So this patient had degenerative scoliosis, and the question was, why didn't you fix it, today, rather than not fix it? And, that's a great question, and it opens up the door for discussion. And the reality is that all my neurosurgery, spine surgery brethren, all my orthopedic surgery, spine surgery brethren, they all believe you have to fix scoliosis to get rid of pain. What I discovered by doing the Duke laser disc repair on patients with scoliosis who adamantly refused fusion surgery, who refused deformity correction surgery, is that by repairing the disc, I was able to eliminate their back pain without fixing the scoliosis, without stabilizing the scoliosis. So without correcting the scoliosis and without stabilizing the scoliosis, I cured their pain. How did I do it? I merely did a debridement of the annular tear at the levels that they were having pain from. So their pain, was it in the L45, L5S1 region? They had herniated disc at 04505S1. I went in endoscopically and I performed the Duke laser disc repair on the annulus and debrided the annular tear with the laser. Guess what? Pain's gone. And it stays gone. Yes, they still have their scoliosis. Yes, they still have their deformity. But the pain is 100% gone. And this happened in 100% of the patients. And to date, it's now somewhere around 500 patients I've done this on. Maybe more, maybe 800. 800 patients. And every single one of them, I've been able to get rid of their pain from their spine without stabilizing their deformity and without correcting their deformity. In other words, you don't need to fix scoliosis to get rid of spine pain. Now, if the pain is coming from the disc, that's the key. And most of the time it is. About 85% of the time it is. Only with extreme scoliosis, like super unstable scoliosis, would the pain come from something other than that. But I can tell you I've never seen that, and every single case I've done with the laser surgery, no matter how bad the scoliosis, the patient's pain goes away. So it's really through trial and error that I discovered this. It's not that I woke up one day and had an epiphany in my thinking. It's truly a result of my work. And it's truly a result of people who adamantly refuse to have major spine surgery with screws and rods, and they chose to have the laser instead, and their pain went away. That's the only reason I truly believe it works, and I surmised from that because all I did was a skin incision, pass through the muscle, and then repair the disc, the annular tear. So by doing that, I figured it wasn't the skin incision that fixed them. It wasn't laying on my table that fixed them. It wasn't the anesthesia that fixed them because that wears off after half an hour. What was the thing that I did that's, the same for every patient? The skin incision was not in the same place for every patient. The anesthetic agent wasn't the same. The table was the same. But the only thing that really was the unifying factor was the annular debridement. And that's when I concluded, and this was back in 2010, when I realized, wait a second, I'm fixing these people's pain by only repairing the annular tear, by debriding it with the laser. So to answer your question, all I can say is, this is knowledge gained through practical experience and observation. And I didn't make it happen, I just figured it out. And it's wonderful because scoliosis surgery is bad. It's major. It's painful. It's risky. It requires screws and rods and derotation and all kinds of osteotomies and bad stuff. So the fact that I can cure pain without putting people through that major surgery, putting them in the hospital, is quite amazing. It's truly a revolution in spine surgery.
Our next question comes from Periscope. The viewer asks, how do you treat back pain caused by autofusion?
All right, so if I understand the question properly, it was posed as, how do you treat back pain caused by autofusion? So let me break this down. Autofusion is extremely rare, first of all, very, very rare. We almost never see it. It does happen occasionally in a condition called ankylosing spondylitis. Outside of ankylosing spondylitis, which is a very rare autoinflammatory condition with autofusion, outside of ankylosing spondylitis, it almost never happens. I could probably tell you one or two cases in every 5 years that I see. So the notion that autofusion happens is very unlikely and very rare. I'm talking like 1 in 1,000. Okay, so it usually occurs in the setting of ankylosing spondylitis, which is like an auto-inflammatory condition, and you can be tested for it by checking for HLA. B27 is the most common serological marker. You need blood tests done. You need a rheumatologist, okay? So let me get to answering the question. Autofusion, the fusion itself, once fused, is not painful, period. Fusion is not painful. What's painful is the inflammation that results in the fusion ultimately. So it's the inflammation of the disc that hurts. And the treatment for that is really, if you really want to know the truth, you can actually go in and fuse those bones surgically. And then there won't be any more inflammation. There won't be any more autofusion because you just fused it. So it will end, right? I know that sounds a little different than maybe you've heard before, but if autofusion is happening in somebody over the course of 3 months and it's painful for 3 months, if I go in there and fuse it today, then it'll stop being painful today. So you can eliminate autofusion pain or inflammatory pain associated with autofusion in these spondylopathy type conditions by doing a fusion. All right, the other way you can do it is by taking anti-inflammatories orally, like ibuprofen, Motrin, etc. If those aren't working or you're having to take them for too long, then you could also do an injection, like a steroid injection called an epidural steroid injection. I think that will help. Again, all you need to do is buy time until the fusion occurs. I hope I was able to answer that adequately for you.
And our last question comes from YouTube. The viewer asks, if cervical vertebrae don't fuse after surgery, but the plate implanted in the front is still holding strong, can you go in the back and put new bone graft into the back of the neck to promote fusion without any additional hardware?
Yeah, great question. So very insightful. Somebody is saying, Dr. Duke, if a patient has a fusion with hardware in the front of their spine, like an interbody fusion with a plate and screws, and the fusion is not taking, the bones are not fusing. So a pseudoarthrosis is developing, or failed fusion. Instead of bone growing between the two bones, you get scar tissue, basically. But the plate is holding well. Can you go in the back of the spine and use bone graft back there to fuse in the back those two vertebrae that you tried to fuse in the front? The answer is yes, you can. And the question was, can you do it without using hardware in the back? The answer is yes, you can. So you can. But what you have to do is, the truth is that fusion occurs between two bones as a result of forces, what are called compression forces, on the bone graft between the two bones. And what happens is your body, as it's fusing, reorganizes the bone graft between the bones where there's compression. So there's a law called Wolff's Law. Look it up. Wolff, like wolf, all right? Wolff's Law basically says that bone will remodel under compression. And so to get a good fusion, you need the bone graft and the bones to be in compression. So if you go in the back of the spine and all you do is lay bone down, there's a good chance it won't fuse. So you have to actually, in my opinion, I would dig out the facet joints using a drill like I did today. Just get in there and drill out the joint and pack the joint full of bone graft on both sides. And then do a little onlay fusion with bone graft on top of the lamina after you decorticate it on both sides. So you would do a interfacet fusion along with bone graft, and then you would do an onlay fusion on the lamina after decorticating them. If you did those two grafting techniques, chances are the bones will fuse. Now, there is one other thing to think about, and that is, why didn't the fusion work in the first place? The most common reasons include the fact that, number one, patient is a smoker, uses nicotine. Nicotine will prevent fusions. So if they were smoking after their anterior cervical fusion and they're going to smoke again after the posterior cervical fusion, chances are they won't fuse in the back of the neck either. So they got to quit using nicotine, period. Not smoking, nicotine. Nicotine's the problem, so stop all nicotine products for at least 2 months after the surgery. Second is basically poor nutrition. So not enough protein, vitamins, minerals. So take vitamins every day, and that'll help the fusion take. Third, immobilization. You want to make sure the spine's immobilized. And if you got what I said about Wolff's Law, you'll understand it's not 100% immobilized. We're talking about like 90% immobilization. So you're preventing extreme movements where the fusion's being taken place at. However, you're allowing micro movements to allow compression forces on the bone graft and the bone graft bone interface to allow the bone to remodel and fuse. So you still need some movement to allow compression for fusion, but you don't want too much movement to prevent fusion and form scar tissue. And then the last thing would be bone metabolism. So people with bad bone metabolism, like osteoporosis, osteopenia, you know, they don't form bone well. So they're going to have trouble making a fusion. So you got to look at all those factors, and you got to make sure you control for them as best as possible to have a successful spinal fusion.
Last question.
That was our last question. So once again, I'm Dr. Ara Jukmajian, CEO and founder of Duke Spine Institute here in Melbourne, Florida. It is January 14, 2021. We have one more surgery left. It's a single level L4-5 Duke laser disc repair for back pain and right-sided leg pain, I believe. Right-sided radiculopathy, we call it, at L4-5. And this will be another 7mm incision, endoscopic, repair the disc. And it's such a wonderful surgery. And there's no bone removed from the spine. There's no bleeding. It's so safe and effective at getting rid of back pain and leg pain. I will say this, if you are new to the Duke Spine Institute broadcast, I highly recommend you go to your app store, download the Duke Spine Institute app. It's very cheap. It's only $1 million to download it. Just kidding. It's free. And it's useful. It's got a library in there. We've got videos in there. We've got testimonials. We've got surgeries, different kinds of surgeries you can watch, like fusions, cervical, fusion lumbar, front, back, sideways, and then laser surgeries. It's just a great resource. Duke Spine also has a Facebook support group for people that are interested in learning more about pretty much anything to do with the spine, and it's called the Spine Surgery Support Group. You don't have to be having spine surgery to go and join. It is free. It's open to everyone. I just tell people, if you're going to go there and try to sell things, don't, because I'll boot you. I've had to boot a few people lately. They're trying to sell things. So anyway, I've enjoyed our time together, and hopefully you're going to go reload on popcorn and Coke and be back for the next surgery, which will start in about 20 minutes.